So now into Module 2, we're going to further explore the classification systems in regards to culture and the concepts of reliability and validity, and finally wrapping up with some of the limitations of the DSM, because it isn't a perfect system, though it does tend to be one that's used pretty frequently around the world and especially in the United States. So let's go ahead and look at culture and cultural norms. So the DSM-5 manual really encourages clinicians to consider the influence of cultural factors in both the expression and recognition of symptoms that might be involved there. So that is a big challenge because, of course, there are a range of cultures that you are probably going to experience as a clinician, and you may not be aware of the specifics of each of those cultures. So that's an ongoing challenge that we have, not just in diagnosing mental disorders, but obviously just in general in our country because of the wide variety of cultures that we do have represented in the United States. So the DSM-5 is not immune from that. And of course, what is normal for one culture may not be normal in other culture. And so that's some of the issues that we run into. And then the DSM-5 even really recognizes what we call culture-bound syndromes. And what are culture-bound syndromes? They're patterns of erratic or unusual thinking and behaviors that have been identified in diverse societies around the world. And they don't easily fit other diagnostic categories listed in the main body of the DSM-5. So I'm going to give you a little bit of an example of what these culture-bound syndromes might look like, okay? And that just goes into what I had mentioned earlier. So one, for example, that doesn't really fit very easily into diagnostic categories is something called bulimia nervosa. And what bulimia nervosa is that kind of binge and purge kind of process that some women and men engage in our society. A lot of times, the reason it's a culture-bound syndrome is in some societies there's no occurrence of bulimia at all. And one of the big concerns that we have is the idea that bulimia is based on our kind of skinny, diet-obsessed kind of ideal body shape, especially for women, and that they begin to develop distorted views of their body. That's why I had that kind of funhouse mirror with that girl in there. And, that's how maybe she sees her body. And so she needs to figure out some way to change it. And some of the ways that people do that is by trying to diet. That fails, they feel guilty, they purge, and a cycle begins to get set up. So that would just be an example of a culture-bound syndrome that happens to reside in the Western societies. And the reason it's in the main body of the DSM is because, well, it's a Western society kind of driven manual. So one that you don't necessarily see is ataques de nervios. And what you see this is people who are from Puerto Rico or maybe around other Caribbean islands may develop this. And it is a loss of control. It's an inability to interrupt dramatic sequence of emotion and behavior. Okay, so it's provoked a lot of times by situation that disrupts or threatens a person's social world. And they do a very powerful outburst of almost uncontrolled negative emotions. And that is somewhat unique in the way that it is displayed. So that's not to say, of course, in all societies, people experience significant disruptions and threats to their social world, but the way that it's expressed can be very culture bound. And so the DSM does recognize that to some degree, but there's a whole variety out there around the world to be aware of. So if, of course, you had somebody of Puerto Rican background or had grown up there and they here in the United States and then all of a sudden display these symptoms, if you're not aware of this particular aspect of a culture-bound syndrome, you may miss that particular diagnosis. So tricky thing and something that's going to be always a moving target along the way here. So now let's talk about more general issues beyond culture, and that is the issue of reliability and then we'll talk about validity in a minute here. But what reliability is and why we're focused on it anytime we're doing diagnosis, it's going to refer to the consistency of measurement. And this includes when we are making diagnostic decisions. And so there are a couple of types that your book highlights here. One of them is what we call inter-rater reliability. And what we see with that is how much two clinicians agree about a diagnosis given the same information. So the ideal, of course, is you have two clinicians, trained clinicians, they get the same data and they come up with the same conclusions. And if that happens every time that somebody used the DSM, then we would say it has an extremely high inter-rater reliability. Now, if you've ever met two people and had them try to come to a consensus about anything that they've witnessed, you know the difficulty of having high inter-rater reliability, particularly with a categorical system where the answers are yes, no along the way. That's going to make things more difficult. So we ideally want any classification system we use to be reliable and have high inter-rater reliability. We also want to see test-retest reliability. And this is how consistent a patient's going to display symptoms between assessments. So in other words, what is the consistency or the kind of continuation of this disorder? And if we say it has high test-retest reliability, it means the individual will probably continue to show those symptoms over a period of time from our two measurement times. Okay, so I'm going to give you an example of some of the reliability in the various disorders diagnosed in the DSM-5 on this next slide here. And what you can see is something like PTSD has a test-retest reliability of 0.67, which is really good in the real world. But you can see it slides down quite a bit. And surprisingly, something like major depressive disorder only had a 0.28, which is a kind of a questionable agreement. And same thing with generalized anxiety disorder. And I got to tell you, I can see that generalized anxiety disorder is a very difficult one to do because you know that somebody's having terrific anxiety difficulties, but to say that they just generally worry all the time and does that meet the threshold, that can certainly be of some disagreement. So as far as children, you can see autism is generally agreed on, and as is ADHD. Conduct disorder is a little more difficult because conduct disorder is very dependent on what the other individuals are noticing, and it can vary across settings to some degree. So just kind of take a look at that, and I think this helps you appreciate that just because one person says that somebody has a disorder of this, this, and this doesn't mean that that's the end-all, be-all. Even among experts, there's some disagreement. Some are a little more liberal with symptoms. Some are a little more conservative. Sometimes two clinicians don't get exact same information, and so they have to go with what they know. And then, say individuals don't disclose something, but then they disclose it to the next person. That's where you're going to lead to some of these issues with reliability. Now, the other part of things that we need in addition to reliability is validity. And that really gets at the reflection of success achieved in understanding the nature of a disorder. So we're looking at how useful is this disorder classification? What does it mean? What is the importance of these kind of measurements? And so there are three types of validity here that we're going to highlight, though there's obviously more than that. One is the etiological validity. Now, etiology, that gets at to what causes the onset. And so if we have some sort of classification system that gets into the cause of a disorder, then we would really like that type of etiological validity. Unfortunately, that's a very difficult thing to do, as I talked about back in Module 1. There's just a lot we don't know, and so that's tricky. If you have something with high etiological validity, that's great, but not to be seen with a lot of these disorders. Concurrent validity, what this is the present time with correlations between the disorder and other symptoms, circumstances, and test procedures that kind of go into it. So what's the correlation between this disorder and other types of symptoms and behaviors? That's concurrent validity. So for example, if we are developing a measure to measure depression, we want there to be some concurrent validity with that depressive measure and another one that maybe has already been established. Because if they overlap quite a bit, you would hope they do, because they're both supposed to be measuring depression. That would be some example of concurrent validity. And then predictive validity is concerned with the course and stability of disorder over time. And so there are a lot of disorders. If you have a chance, and I really should, I don't think maybe I've mentioned this in prior lectures as much, but I really encourage you, if you can, to get a DSM-5, especially if you're a psychology major and you think this is something that you want to go on into. It will pay off, not just in this class, but you'll see it come up in many of the other classes you'll be taking. And it can be just an interesting read because they do have a whole kind of review of the literature regarding the course of a particular disorder, which would get into this predictive validity thing. So you would hope that if you can make a diagnosis, that you can get an idea of do these disorders last and tend to be long-term, or do they kind of flare up and then they kind of tend to go away? And that's really important to know. Okay. So validity is not an all or none. It is a degree of kind of how useful these are. So, nothing's going to spot on get the etiology of a disorder, but they do have possible signs, so things like trauma certainly contribute to a whole range of disorders that we have out there. Okay. All right. So let's talk a little bit about some of the problems and limitations with the whole DSM-5 system. Now, as I've already talked about, the DSM-5 is categorical, but a lot of disorders appear more dimensional, and so it's not a great fit. And as I was mentioning, there was a talk here not too long ago, continuing ed talk as part of our PsyD doctoral program, that really went into detail of using a dimensional approach when considering personality disorders. And you'll see what we mean in that chapter, because your book talks about it quite a bit. Also the issue of where is that boundary? What's normal and what's abnormal? And where does that barrier get crossed? That's very difficult to have that dividing line. Usually you're trying to use that as how much issue have they encountered in their environment? Is it really impairing them to a significant degree? But that's still very inexact. Measuring impairment, there really is no specific measure that provides or declares a particular impairment level. It can get an idea, but there isn't something that just says, yep, you got that, boom, that's what this is. And then what is kind of these conceptual issues? So the way that syndromes are defined sometimes is just not useful. There's some politics involved with this. It's not just all rigorous science. Sometimes people really debate quite strongly about a variety of aspects in regards to the DSM and in particular disorders. And sometimes once a disorder's in the DSM, even though the evidence kind of piles up that this isn't the best way, people have gotten used to it and they're like, don't change it on me. We find it very useful. So there's that factor to kind of think of too. Some other issues, there is a problem of comorbidity. Now, when we talk about somebody having comorbidity, what we're referring to is that two or more disorders are appearing at the same time in the same person. Okay, so we know that comorbidity is quite high for mental disorders in the DSM-5, and they actually encourage you to diagnose multiple disorders. What the focus of the DSM is really trying to capture the best picture of a person, and many times you got to have more than one diagnosis to do that. But it makes for kind of a sloppy system. People don't fit neatly into categories. They usually are a lot of times kind of overlapping, and the clinician really has a challenge in trying to break those down. About 56% of those who met the criteria for one disorder also meet the criteria for at least one other. So over half of people who come in to have any type of diagnosis are going to have comorbidity. When comorbidity is high, the meaningfulness of the diagnosis is weaker because If you constantly are having things overlap with one another, then are you really measuring two separate things? Okay, that's the question that you want to ask. Um, and it really highlights when we have so much comorbidity, kind of the longitudinal course of these symptoms of one or more diagnoses. In other words, if you keep going from one disorder, like at a certain age, you get this type of depression. But if it goes on longer than that, maybe it moves into a separate type of category of depression, then maybe moves back. And then you're like, but this is the same person. Maybe this isn't really all that different that we thought it was. So, not a perfect system, but it is the one that rules the land right now. So we're going to spend a lot of our time this particular course looking at the DSM-5 related categories and kind of illustrating from there. So we've gone over the fact that culture comes into play when making these diagnoses, that when we look at any system that we want to use, especially the DSM-5, we want to be able to have reliability and validity, and that will help us in our eventual treatment of those individuals. And then finally, it's not a perfect system. There's things like comorbidity and lack of measurement agreement, and even considering how the course of the disorder goes. So now we're going to look at how do we assess this? How do we get to the point where we have reasonable type of confidence in the type of diagnosis we do? And so we'll look at some basic assessment issues in Module 3 and include kind of an overview of what the interview format looks like. So stay tuned for that one.